Welcome to Grand Rounds. It's 12 o'clock and I think we'll start. I'm Barry Casson, internal medicine and chair of the Grand Rounds. And I'd like to welcome this site and other sites. And I'd like to acknowledge that we're gathered on the traditional and ancestral and unceded territory of the Coast Salish peoples. Today's Grand Rounds is entitled Lessons Learned from Monkeypox. And we have 3 members of the Division of Infectious Diseases from St. Paul's Hospital. Dr. Victor Leung is going to be leading off. I'm not sure who he's handing over to, but Dr. Mark Hull, I guess, will be next. And Dr. William Connors. So without further ado, Victor.
Good afternoon. Thank you for joining for this Medicine Grand Rounds. Here's our disclosure slide. So Will and I don't have any conflicts related to this presentation. Mark is a co-investigator of a placebo-controlled RCT of tecovirimat for non-hospitalized patients, and he's also on the provincial guidelines expert group. So today we'll be discussing some of those aspects. Our hope is that by the end of this rounds, you will have a understanding of the context of the 2022 monkeypox outbreak. Oh, sorry, if you're online, can you please mute? Eugenia, if you're online, can you please mute? Thank you. So that you can try to understand the significance of this current outbreak and what are the implications. Hopefully you'll also be comfortable with clinical diagnosis of common cases as well as laboratory diagnosis and the clinical management of community and hospitalized patients, at least the basics of that. And then also be familiar with our main preventative strategies and countermeasures, which is vaccination. And so I'll start off with talking about the situation update, and I'll hand it over to Dr. Mark Hull to talk about the clinical diagnosis and management of cases. And then finally, Dr. Connors will go into a bit more detail on vaccinations. So a little bit, just one slide on the virology so that you have a sense of where this virus is. This is a double-stranded DNA envelope virus. It falls within the pox viridae family. And of the pox viruses that are known to infect humans, this falls under the orthopox virus genus. Vaccinia is an example of a orthopox virus. It is used in some of the vaccines. Variola causes smallpox, and monkeypox is the etiologic agent of the human monkeypox disease that we're seeing. Cowpox is also one of the viruses in the orthopox viridae, but less common. Another common pox viridae is the molluscum contagiosum virus that causes a disease well known to many of you. So a little bit about the history of monkeypox so that you can see when it was discovered and sort of the timeline of major milestones. This virus is called monkeypox because it was first identified in monkeys. These monkeys were shipped from Singapore to Denmark at the Statens Serum Institute for use as laboratory animals. 62 days after the shipment, they started to develop vesicular pox-like lesions. And from then on, investigations, including electron microscopy, were done to characterize this newly identified virus, which was named monkeypox. However, since then, we have not been able to identify a natural host for this virus. The only time it's been isolated in the environment is from a squirrel in Zaire. Otherwise, it's thought to be circulating enzoonotically within rodents in the community and then transmitting to other animals and to humans periodically. 1970, 12 years later, was the first time this virus was identified in a human. This was in a 9-month-old boy living in a Democratic Republic of the Congo. He presented with disseminated pox-like lesions, which were then identified as monkeypox. He survived this episode, but then 3 weeks into hospitalization, subsequently died of hospital-acquired measles. In terms of investigating the source of this, there was never identified a clear link, although the family did report eating monkeys, and so it is possible that the boy could have been in contact with the carcass, with the skinning process, but unclear. In 2000, finally, some infrastructure resources were put in place to have enhanced surveillance of this disease in the Democratic Republic of the Congo. And you could see that since 2007, there has been increase in number of cases, but then the enhanced surveillance stopped because of funding and lack of interest in this disease. It wasn't until, during this time, they also investigated human-to-human transmission. And from the Democratic Republic of the Congo investigations, the longest human-to-human transmission chains were up to 6 chains of transmission. So keep this in mind as we think about how many human-to-human transmission chains have existed now since the 2022 outbreak. The first time that this disease became kind of more awareness outside of Africa was in 2003, when prairie dogs that were housed with giant Gambian rats from Africa. That was the source of the monkeypox virus. And then from there, human transmission. However, in this outbreak, which was published in the New England Journal of Medicine in 2004, there were 47 human cases. What's interesting is that there was no human-to-human transmission identified. All the transmission occurred from animal to human contact. And it seemed that the highest risk were among humans who most likely had daily contact with animals, children who were petting the prairie dogs, as well as people who cleaned some of the cages. What was interesting in terms of better understanding transmission was that there were animal health workers who had no contact with the animals that still acquired monkeypox. So it brought into this question of what are the modes of transmission? Is it predominantly through fomites? Could it have been airborne? Some of the initial outbreaks in zoos in Rotterdam. In 2008, we were warned that this would become a problem. With changes in vaccination, the cessation of smallpox vaccination, waning immunity, cases started to increase in the younger population. As well, they were also facing geopolitical instability in the Democratic Republic of the Congo, food insecurity, deforestation, and of course, climate change as a significant risk factor for transmission of zoonotic diseases. And so you could see that there's been an increase steadily since 2009. And in 2017, the first cases were identified in Nigeria with a large outbreak that continues until today. The Nigerian CDC had previously asked for support from European CDC, CDC Atlanta to better control this outbreak, but those calls for help were not met with any significant responses. As a result of this outbreak in 2017, there were 4 cases since then of transmission through travel. So in England, in Singapore, Israel, these were fortunately limited cases without further identified human-to-human transmission. It wasn't until May of 2022 when we first heard of another imported case. So this was a case of a man who traveled to Nigeria in late April. He presented in the UK with disease that was identified and confirmed to be monkeypox. A week later, there were 2 more cases identified. And then subsequently during that subsequent week, there were 14 cases identified. What was unique about these cases was that there was no travel history to Africa. And also majority of the people who had presented with monkeypox self-identified as gay, bisexual, or men who have sex with men. And this started what was criticized to be a delay in messaging because of a lack of ensuring that we didn't want to stigmatize populations, but at the same time communicating to people who are at risk. So there was some criticism initially of the CDC in terms of its messaging. But through working with community advocates and providing clearer messaging, it is now pretty clear that this is predominantly transmitted through close sexual contact. You'll hear more about that in a bit. And so on July 21st, this was declared a public health emergency of international concern by the WHO. This is the 8th time that that declaration has been made. And as a result, more measures and resources were put in place to try to control this outbreak. So first of all, the situational overview from a global perspective, there are now approximately 72,000 confirmed cases. This is updated on a dashboard from the WHO on a daily basis. There are 28 deaths. Of the deaths where cause is identified, encephalitis is a common cause. In other cases, it hasn't been clearly linked as to what the cause of death was. 109 countries have cases, and Canada ranks number 9 in terms of countries with the highest number of cases. If we look at the cases where more detailed information is available, you can see that of approximately 41,000 cases, 97% are in male, with a low, sort of a younger age group, 35 years. And of that group where more detailed information is available, men who have sex with men is identified as a risk factor. As well, patients have comorbidities, including being HIV positive. Some have a travel history. Where transmission is identified, sexual transmission is the number 1 kind of mode of transmission. However, it is important to note that in this table where you can see the case profiles, there is a lot of missing information. So despite that this is declared a public health emergency of international concern, the ability for the WHO to collect detailed information in terms of risk factors is still limited. Now we shift over to Canada. Canada, again, the 9th most common country with cases. We currently have 1,411 cases as of October 7th. And if we look at the distribution, most provinces have reported cases, with Quebec, BC, and Ontario being the highest. In Canada, the epicenter of the outbreak started in Quebec. Now, looking to the BC situation, as of October 5th, we have 167 confirmed cases. In this epidemic curve, our initial case, although was identified in June, the first onset of symptoms was back in May. Currently, most of the people who are affected in BC have no travel history, which, like many countries, has confirmed that there's ongoing community transmission among those who are at the highest risk. And I think an interesting point is that a quarter of all cases had a known contact with either a monkeypox case or with a person with symptoms of monkeypox, which means that 75% of people presenting with monkeypox have no idea where they got it. Some people have multiple sexual partners. And so this brings into the question of how transmission is occurring if they don't identify a source. Is it because the symptoms are so mild or the lesions can masquerade as other common skin lesions, which Dr. Hull will talk about? Or is it because there's asymptomatic transmission? And in the literature, there have been case series looking at enhanced surveillance of samples taken for other purposes, such as gonorrhea, chlamydia, and HSV testing, and have identified, at least in the patients with gonorrhea and chlamydia testing, have identified asymptomatic cases. Most cases here have been acquired locally, and 4 of these cases in BC were identified through enhanced surveillance through testing of samples submitted for herpes simplex virus. So BC CDC implemented this enhanced testing a while back, and so far has identified 4 cases, which highlights the point that when you think about herpes, varicella, you also should have monkeypox in your differential diagnosis in the right setting. So it's 12:14. I'm going to pass this on now to Dr. Mark Hull to speak about the clinical presentation as well as management aspects of people presenting with monkeypox. Thank you.
Thank you. I'm just going to carry on from where Victor left off and just have one slide that highlights again, I think, some of the tricky parts that we're going to face in terms of, I think, eventually eradicating this epidemic, which is the asymptomatic carriage and transmission, potential transmission of monkeypox. So there are studies that Victor has alluded to from Europe now. 2 different centers have been able to find, if you're collecting routine samples for STI screening, that people will actually have evidence of monkeypox without any clinical symptoms whatsoever, which I think speaks to some of the difficulties we have in terms of tracking these chains of transmission and interrupting them with post-exposure interventions. From a clinical standpoint, I think we have to try and put into context what we're seeing now with this current epidemic compared to what has been reported in the literature from the classic disease that was reported in Africa over the last few decades. So in that context, the rash, which we'll see some pictures of in a bit, started traditionally on the face. You might see similar eruptive stages occurring at the same time over the body, which is quite different for some other viral things, which tend to evolve down nerve pathways. And there was a very high likelihood of involving palms and soles. So something on the differential if we think about syphilis or things like that. And I think a lot of people in our study were initially assessed for syphilis and then found to have monkeypox. In that original data set from Africa, mucous membrane involvement was fairly common. So you did actually even have in that data set about 30% of people having genital lesions and a fairly high burden of oropharyngeal lesions. But as Victor has alluded to, and we'll hear more from Dr. Connors in a bit, is if you had had a previous smallpox vaccine, this was highly protective, both in terms of diminishing your risk of getting monkeypox, but if you did develop monkeypox, having a much more mild disease course. So fewer skin lesions, less confluent skin lesions, less mucous membrane involvement. And I think we're definitely seeing this and now in people who are acquiring infection despite being vaccinated here. The incubation period from time to exposure in the original monkeypox series was about 5 to 21 days. And some authors have divided this into 2 stages. So what they call a pre-eruptive stage, where somebody has a lot of systemic symptoms, fevers, myalgias, back pain, headache, very common, lymphadenopathy, very common. Classically in that series was cervical. In the more modern series, we'll see as mostly inguinal, actually, but very prominent as a potential finding. And you may have skin lesions occurring at the same time, but usually this followed a few days later. So hopefully you can see this very nice figure from this preprint. They basically divide the lesions going through a series of stages, starting as a flat macule, so over here, and then becoming more obviously pronounced as a papule into a vesicle and potentially a pustule with more milky fluid inside of it, and then eventually bursting and going through its scabbing phase. And so you might see people just have a small eschar instead. So as Victor has alluded to, there can be complications from this infection. Often these might occur locally, so bacterial secondary infections, so cellulitis or impetigo. If you do have lesions on your eyes, there's a risk of corneal involvement, an ulceration, pneumonia, diarrhea, and some of the deaths now that we've heard about have included encephalitis, which is actually seen in the monkeypox outbreak in the US back in the early 2000s. Several children had encephalitis as a picture. With our current monkeypox, we have quite a bit of data now arriving from Europe, which was the initial epicenter of the infection. So the incubation period is about the same, so about 8 to 9 days after exposure, as short as 4 days, and as long as almost 3 weeks after exposure. The clinical symptoms, I think, are best described in the initial case series that was reported in the New England Journal. So this is the article from the SHARE network. And you can see, if you're familiar with any of the authors, this involves a lot of our colleagues who do infectious disease in Toronto and Montreal. So Sharon Walmsley, Marina Klein, Daryl Tan, some of the major HIV clinic specialists in Toronto and Montreal. In this initial analysis, which is 587 people, you can see the description from the demographic standpoint is very, very similar to what was reported now globally by WHO. The median age was 38, most identified as male, majority were men of sex with men. And you can see in this context, part of the reason why they're presenting in full care with infectious disease is they were living with HIV or being followed through some of the HIV prevention clinics, such as PrEP clinic. So Dr. Connors and I work at the Health Initiative for Men across the street, And that clinic has really been the epicenter of monkeypox in the province. I've seen about 60 of the 160 people through that clinic. And you can see as well, you can't forget about other STIs. About a third of them had a secondary STI at the same time, so syphilis or gonorrhea or chlamydia. And we could see already in May and June that the majority of people were acquiring the infection locally. There was very few that had reported foreign travel as part of their risk profile. So what do we see now? Now we can see with this most recent epidemic, very clear evidence this is probably coming from exposure at the time of sex. The majority of lesions are actually occurring in an anogenital disposition. So anal or penile lesions, very few on the face, very few on the palms and soles. And a significant minority of people had a discrete set of lesions, so less than 5 in total. So not widespread lesions as we sometimes see in the pictures in the literature. The other common finding, and I think one of the most difficult ones we've had to manage, is the really severe pain that accompanies the proctitis aspect of it. In the original case series, 13% of people required hospitalization to manage their pain or bacterial secondary infection. And in Toronto, they had 2 additional cases of myocarditis, where people were admitted to the cardiac service for myocarditis, and 1 patient was in the ICU for epiglottitis. But luckily, fortunately, so far in a Canadian context, we haven't had any deaths. So what do some of these lesions look like? Some of the people that we've been looking after have agreed to have their picture shared. And you can see they can start fairly discreetly as these very small vesicles, often with a bit of an erythematous space. So it makes us think a little bit about zoster or herpes. But then they will evolve over time. So in a day or 2, they become much more obviously pustular. And I think one of the characteristics that you can notice here is that the very central sort of molluscum type appearance with that umbilicated lesion. I would say in almost all the people that we've seen, eventually they'll reach this sort of picture where they develop much more clear umbilication to their lesions. Perianally, you can see why it's so painful. You get very large numbers of these lesions occurring. And in the case series from the New England Journal on colonoscopy and sigmoidoscopy, these basically go all the way up into the rectum, and it's excruciatingly painful to manage. Very, very rarely, we have seen people present with much more disseminated or confluent skin involvement. So this person presented with what we thought was syphilis, as you could probably guess looking at that picture. And in fact, he did not have syphilis, and just a regular viral swab of his skin, just rubbed over the confluent area, actually was positive for monkeypox. So a very unique presentation. One of the areas that makes it quite hard for people to be picked up at is if they're fairly mild and they start to heal over and start to scab over, they look like this. And this person came in saying, oh, I had a really bad hiking trip and got bitten by mosquito bites all over my body. And we swabbed, of course, both his hand and his knee. And he did not have monkeypox. He had monkeypox, not mosquito bites. So I can see why people are very often easily mistaken in terms of their self-diagnosis if they're not having a lot of pain with their lesions. In some individuals, they've gone on to have much more significant scabbing and eschar. And you can see in this individual that he had some bacterial secondary infection, a bit of impetigo starting around his chin. So a very wide set of manifestations dermatologically. It's been very, very fascinating to see. So what to do if you're suspecting monkeypox? We've basically broken this down into 2 possible areas where you might see somebody. Somebody presenting with fever, myalgia, headache, possibly lymphadenopathy, but you can't identify at that point any obvious skin lesions. In that situation, you can sample a number of body sites where there might be a higher likelihood of shedding their monkeypox. So if you use a standard Copan viral swab, the viral transport media, you can order monkeypox PCR from a blind or a pharyngeal or rectal swab. You can actually send an EDTA sample to the BC CDC, and I think maybe St. Paul's is doing blood as well. And you can actually order a urine sample for monkeypox PCR. Once they have a skin lesion, then this becomes much more easy. You de-roof any vesicles, but for those scabs and eschar, you don't actually have to be that aggressive with them. What we've tended to do, just so you don't cause more damage to their skin, is just put a few drops of sterile water on top of it and gently swab the surface, and it's very easy to pick up monkeypox in that sort of skin lesion. In BCC, At the moment, we're very fortunate. 3 labs are offering monkeypox testing. St. Paul's lab is one of them. The BCCDC has done the vast majority. And you can see they performed just over 4,000 tests to identify these 165 or 67 cases that have been positive. The other aspect that they've been able to tell us is if you sample multiple skin sites, the yield is very, very high. You can actually use the same swab in a number of different skin lesions to increase your pickup for the monkeypox. And as we've talked about in the prodromal phase, they have had success with rectal samples. This has been a very highly successful diagnostic yield. And this is reported as well now from some of the European sites as well. Those people then will tend to usually in the next few days go on to develop clinical symptoms and lesions. So what to do if you do have somebody with monkeypox? And here at the moment, unfortunately, most of our management has really been focused on supportive care. I have to say that pain control has been one of the most tricky things to figure out because people tend to escalate very quickly in their symptom profile. You see them on day 1, they don't really have a lot of symptoms, but by the second day, they're at a 10 out of 10 or 11 out of 10 for rectal pain or oropharyngeal pain. A lot of people, if they have genital lesions, tend to get a lot of edema. So a lot of difficulty sometimes with swelling and actually initiating the urine stream. But so far, we haven't had to send anybody to urology for catheterization. I've tended to use a combination of escalating pain medications in terms of Tylenol with codeine, tramadol, sometimes even narcotic medications. Interestingly, gabapentin has been highly effective at helping with a lot of the symptoms. And for the swelling, I've tended to use a lot of hydroxyzine, or a very nice antihistamine. And I think it helps them sleep, which is really when the pain tends to get worse is at nighttime. We've had a number of people show up with bacterial superinfection. So cellulitis, lymphadenitis, we've had a few people go through OPAT for this. So far, luckily in BC, I'm not aware of anybody having eye or cardiac involvement, but definitely could be some of the more severe manifestations. And as Victor has said already, some immune-compromised people have presented with encephalitis. There is one antiviral agent that has potential activity against monkeypox. It works at one of the viral proteins to stop creation of the virion and therefore dissemination within the host. This medication has been approved for treating smallpox. There's animal data to show benefit for monkeypox itself. And there is a case in the British literature where one of the cases there was treated with tecovirimat several years ago and had less symptom burden and shedding of disease. In our latest data set, the SHARE study from New England Journal, 2% of people were treated with tecovirimat, but they didn't distinguish the outcomes for those individuals compared to people just having standard of care. And a case series at University of California at Davis has just been released, but again, it's purely descriptive. They told us about the people that they treated, and you can see that 92% of people had resolution of symptoms at day 21, which is sort of the natural history anyway. So it's a little bit difficult to know what the role of tecovirimat is for outpatients. And the FDA has raised some warnings in that there's only a mutation needed for it to become resistant to this medication. In British Columbia, you can apply for tecovirimat therapy for inpatients or people with severe disease manifestations. And this would be an initial 7-day course of treatment and then review for extension if they were improving or not improving. And you can download the application form off the BCCDC website. This is sent to a review committee to evaluate on the benefit of starting tecovirimat at that point. And I think we've had two people that I know about that have been treated in the province so far. We are in the midst of setting up a pan-Canadian RCT to look at the benefit for improving symptoms or shedding in an outpatient setting. So it'll be us, Toronto, and Montreal. From a public health point of view, the public health officials are closely involved in assessing people at the time of their diagnosis. They look for risks of transmission to household contacts and potentially through fomites, so bedding or towels, and give people advice about minimizing sharing some of these common surfaces with individuals, wearing a mask if you're in a tight space due to the risk in the first few days, perhaps of respiratory droplets, although this is still a little bit unclear. And then the real question we have to ask ourselves is there any risk for long-term shedding? So some of the UK data has showed that the virus can persist in seminal fluid for several weeks. Whether this is actually infectious or not is somewhat unclear. But in the UK, they do recommend condom use for several weeks. after you recovered from your main illness. I'm going to pass it over now to Dr. Connors. He is going to be focusing on the next aspect of public health interventions, which is our vaccination strategies.
Great. Thank you very much, Mark. Pleasure to be speaking with everyone today. It's daunting to come after Victor and Mark, but I get to be the cleanup here. So I'm going to focus on countermeasures and really focus on vaccines, as this is our primary intervention. I'm going to take you through a little bit of history because there's rich history here, and then I'm going to highlight a bunch of the unknowns because there's a lot of unknowns for how we apply this to our current outbreak. And so, as mentioned at the beginning, in terms of virology, when we're talking about pox viridae, there's a couple of viruses within this family that will be sharing very similar immunologic response. And so a lot of crossover. And this is the principle behind vaccinology for pox viruses. Historically, Jenner was the one that's been credited for taking the observation that milkmaids had very fair skin and did not tend to get smallpox, and realized that perhaps it was the cowpox that they were exposed to that was giving them protective immunity. Then inoculating individuals with cowpox led to evidence that it prevented smallpox, a much more severe disease. And so that nodus between cowpox and variola or smallpox was noted as kind of the early evidence for vaccinology, and Edward Jenner's been popularized as the father of immunology and vaccinology in that regard. Subsequently, as we developed a vaccine approach to the global smallpox pandemic and its later eradication, we started to use vaccinia virus, which is thought to have some roots in potentially the horsepox virus and cowpox virus. And so it's a highly attenuated laboratory strain, and that's used in the smallpox vaccines. And we do now know that the monkeypox virus has some overlap, and the use of smallpox vaccines are now used for monkeypox. To give you the lay of the land in terms of the types of vaccines that we have, there's what we refer to as the 4 generations, really 3 major generations. The original or first generation is the vaccine that we used heavily during the global eradication of smallpox. So these were derived from agricultural production, actually the lymph of animals, calves. They'd suck the lymph out of them and they create a dry vaccine. And these were utilized and then modified into the 2nd generation, which was an attenuated form of the live virus, still able to replicate, but not as efficiently. The 3rd generation that I have listed here, and this is doing the workload for treating monkeypox now, and is the modern smallpox vaccine, is a highly attenuated, although live virus, it's not replication competent in humans. And the name here for these vaccines that you'll hear, the trade names in Canada is Imvamune. That's the vaccine we've been using. And in the United States, it goes by the trade name Gyneus. I haven't had someone pronounce that for me, so I could be presenting it wrong. The Japanese also have a 3rd generation and now a 4th generation vaccine that is, again, a highly attenuated, but this is potentially replication competent in humans, at least the 3rd generation. And that one's not available in Canada. That's the LC16M8. Referring to the Imvamune vaccine or Gyneus vaccine, the other name is modified vaccinia ankara, and that's the actual vaccinia virus. This is actually a common vaccine platform that's used because of its immunogenicity. And so the new Ebola vaccines that they're developing actually use that modified vaccinia ankara. So why did we go through these generations of vaccines, and how do we end up with this 3rd generation that I'm going to focus on in terms of our public health response? Well, it really has to do with the side effects and the safety profile. So that second and historic 1st generation, one example would be the ACAM 2000 vaccine. That is that's the stockpiled vaccine for smallpox that has been primarily reserved for military recruits and biosafety. A huge stockpile in the US and likely Canada too. That vaccine was given through a percutaneous abrasion to the skin, a single dose that led to a take. That's the classic scar. And if you know anybody that 50 years ago got their smallpox vaccine, you'll see that classic scar on their shoulder. That take was a reflection of the virus triggering immune response, but also you could have progression of disease. Remember, this was a replication competent virus. And so you could, in immunocompromised hosts, get disseminated disease. In individuals that had skin conditions like atopic dermatitis, this was contraindicated because it could lead to local and then systemic progression. So that vaccine's downfall was those complications, as well as the risk for individuals having severe complications if they had compromising conditions like HIV, immune suppression. It was contraindicated in pregnancy and infants and individuals with atopic dermatitis. It did get approval for smallpox, and it has now had emergency approval in the US for monkeypox, but it has not been formally approved in Canada for use. The third generation and the focus of what we're going to talk about in our vaccine campaign are these, what was originally a subcutaneous live virus that's non-replicating in humans, and that's that Imvamune or Genios vaccines. So 2-dose regimen is what's been studied. This comes from smallpox trials that were performed in military recruits, primarily in the US, as well as studies in animals looking at the non-human primate data. The benefits of this is that although it has local vaccine site reactions, it does not have those severe manifestations and does not have the systemic complications. So it is safe to use in immunocompromised individuals, individuals with skin conditions, and there's a safety signal in infants and pregnancy, although it's not formally approved. So Health Canada, as well as the FDA, has provided emergency approval for this. It is formally FDA approved, and Health Canada has emergency authorization. So just a reminder, the original smallpox vaccine, you may have seen this. This was the bifurcated prong or the needle that they would braid the skin, so a percutaneous mechanism. That was with the first and second generation of smallpox vaccines, but not with our new subcutaneous. So what do we know about the effectiveness of this vaccine for monkeypox? Well, there's a lot we don't know. What we can use is a couple of different types of data. So we have historic data, and this would be the cohort of individuals that had received smallpox vaccine through the global campaign or subsequent vaccination. There are cohorts such as our military recruits that still get smallpox vaccine. And so from those, if we look at Central Africa, we know that the cohort that was vaccinated historically with the vaccinia or smallpox vaccine has reduced rates of monkeypox, where monkeypox is endemic in Central Africa, like the Democratic Republic of Congo. It's thought to have a 5-fold reduction in risk of monkeypox infection, and the efficacy of that historic smallpox vaccine is estimated at between 80 and 85%. There are a number of knowledge gaps in terms of applying this to the modern monkeypox outbreak, as this is a West African strain, a different clade. As well, there seems to be different routes, and whether vaccines are protective at those routes of contact is still unknown. And we're also using it for post-exposure, and I'll talk about that, but these were largely pre-exposure vaccine studies. There has been animal non-human primate challenge studies, which would be a gold standard, challenge somebody after vaccination. And that's where we get most of the data that led to the third generation monkeypox vaccine approval. So told you about history. One of the fascinating things is we talk about monkeypox, but look back at how we approach smallpox. Really, one of the crowning achievements of global public health and vaccine, the eradication of a disease. And so over the summer, I was reading an excellent book I recommend everybody called House on Fire. It's a book by Bill Fagey. He was one of the former CDC directors. And the term comes from really what his approach to working with the Indian government and public health infrastructure was to eradicating India's smallpox, and really focus of the epidemic. By the 70s, that's where smallpox was. And the title House on Fire comes from a saying that if there's a house burning in a village, you don't run and pour water on all the houses around it. You go put it on the house that's on fire. Yet a lot of what we were doing in our vaccine campaigns for smallpox, and effective in some places with mass vaccination, and forgetting to go to where the problem is. And so this is going to be a focus of what I talk about when we talk about the monkeypox approach, which is really going to where the house is on fire. I have here a picture. The outcome of the Indian smallpox eradication campaign was really what they referred to as a hybrid approach of surveillance containment, utilizing ring vaccination and aggressive search and control of infections. It's amazing when you look at the graph here on the right of the slide, how quickly with this intensified approach, they were able to drop from hundreds of thousands of cases a year, despite millions and millions of vaccines systematically across India, to using this search and contain approach, dropping very rapidly. And this was the real turn in terms of eradication globally. So when I talk about vaccine approaches, a couple of terms I use is PEP and PrEP. You may be familiar with these terms. PEP is the idea of post-exposure prophylaxis. Another way to think of this is ring vaccination. So you know there's a case, you go to the people around them, knowing that they may have shared risk and contact. So the PEP approach was our initial approach. We saw a case, we went and tried to deliver. Then came PrEP, which was a pre-exposure prophylaxis, more of a passive approach, encouraging individuals that are at risk to come get vaccination and reaching out to sites where at-risk individuals may be, such as men's health clinics, venues where people are receiving HIV or STI care. There in the States is a term called PEP++. So this is expanded PEP. And what they were saying was that although they may not have been known to be a discrete contact, if you were at a venue where circulation of monkeypox was likely, they considered that post-exposure prophylaxis. And just interpreting some of the data, it's important to know those terms. So applying that, and these are the updated recommendations now, NACI, our national body for vaccine guidance, as well as the BC CDC, has begun to integrate this into our vaccine recommendations. And we've rolled out vaccines in British Columbia now since, I believe, June or early July. And so if you're trying to figure out, should you get vaccinated or should your patients get vaccinated, I put here kind of a quick stepwise approach. So first of all, make sure they haven't had monkeypox. We know that it's highly immunogenic, and that likely provides them with protection if they've had it. Then think about post-exposure prophylaxis. And this is what public health is working very aggressively to go out and find people at the high-risk sites and identify case contacts if possible. But as Mark was saying, that's not identified for a lot of our cases. Those individuals that have been documented as a candidate for PEP should be offered it ideally within 4 days, but up to 14 days, because we know this vaccine can attenuate illness, even if it doesn't prevent it. Then comes the PrEP approach. So this is based on risk of exposure. And I've listed a number of the risk groups here, and I've highlighted some of the differences between national guidance and the adopted provincial guidance. One of the things that's really important to understand about the vaccine approach in British Columbia and Canada is that this is a biosafety issue as well. These vaccine stocks have been reserved for potential smallpox bioterrorism and smallpox outbreaks. So there's been a lot of reservations about using them or deploying all of these vaccines. And so they've tried to be somewhat strategic. They've also been somewhat cryptic about how much our store is. They released about 70,000 vaccines in Canada, and it's unclear how much we might have. So supply chain has been a major factor for the provinces getting their requested vaccines. You can see the listed high-risk groups here, and I'll let you read that yourself. What's interesting is that occupational and environmental risk is something that the national guidelines have, and this isn't actually healthcare workers. There's been very few cases amongst healthcare workers, and if we adhere to the guidance that Victor and our infection control practitioners are telling us about prevention, it really should make that negligible risk. There have been, I believe, 9 reported healthcare worker infections last time I looked globally. And these are typically in places where there has been no suspicion or lapses in infection control. So this risk environment is if you work in a bathhouse or you work in a venue where there is high risk sexual contact, these individuals we might read out to as a higher risk group for PrEP. So what does this look like implemented? Well, in British Columbia, the vaccine campaign starting towards the end of June initially was that PEP focus, that post-exposure, really chasing the cases and the people around them. There was a very creative approach to this in BC. We have a rich history of reaching out to marginalized groups, particularly engaging and providing care to the GBMSM group. And so HIV clinics, sexual health clinics, venues where sexual transactions were taking place were all targeted early on for initial rollout of the PEP and then PrEP approach. By early July, they were focusing on PrEP, and vaccine took off. That's when we started vaccinating heavily, and the line in the graph here is showing the total cumulative number of vaccines, and you see by early September, it starts to plateau. We're starting to see some saturation. One of the things that was done was modeling, well, how many people would be at risk in this group? And the estimate that came up was about 28,000 individuals in British Columbia would be considered at risk. And so by the October report that was released by the BC CDC, we vaccinated about 19,000. We've had a little over 160 cases, and that, as Mark has tested, around 4,000 tests have been done. You can see the breakdown by health authority here, and this multi-prong approach has been super important. This has been an approach of engaging providers like dating apps or sexual hookup sites online. So Grindr and other apps will have notifications in them for case contact, down to Stanley Park, where there may be casual sex. There may be individuals down there offering vaccine for this higher risk population. And so there's been a bunch of outreach by our public health colleagues. So what do we know about applying this approach and this vaccine to this outbreak? Well, there's really scant data. Fortunately, towards the end of last month, the US began to report some of their data. There's a lot of challenges in obtaining this data and having high quality data, given the limitations in linking testing and vaccine rates at a population level. But their estimate, as shown here, unvaccinated the top line, vaccinated the dotted line on the bottom, over this 1 month period, really the month of August. And for context, think the US has had about, I think they've had about 25,000 cases. So certainly a huge bulk of the cases globally. And they've vaccinated about 300,000 individuals. So what did they find from this data? They found about a 14-time reduction in the number of individuals that were vaccinated compared to unvaccinated having developing symptomatic or confirmed monkeypox. This was looking at individuals between the ages of 18 and 49, and specifically amongst that gay, bisexual, and other MSM group, the high-risk group. Why 18 to 49? Well, that's going to be the cohort historically that didn't get the previous vaccinia vaccine that could confound some of the findings. These looked at individuals that received the equivalent of Imvamune in the United States. Now, there's been much discussion about how much can we extrapolate from this finding. Majority of this was one-time vaccination. It was from 32 jurisdictions in the US. And there's a whole bunch of challenges in terms of you may not be reaching the individuals because they have subclinical disease. So you're missing a lot of cases that didn't present and have confirmation. There's data linkage issues at the state and the national level in the United States that they highlight in this paper. But this is preliminary and promising information about the efficacy of this vaccine. They do encourage the 2-dose vaccine series, which was not received here. The vast majority, I think 95%, were single-dose recipients. So now looking at in British Columbia, this was kindly provided by the BC CDC, and it gives you a nice summary of the evolution of cases and vaccine status. So if you look across this timeline bar graph from the left to the right, you'll see the predominance is the red. This is not vaccinated or unknown previous vaccination status, so presumed not protected. So they still make up the majority of disease, but over time, you start to see other groups become more common. So that unknown vaccine status is blue. The childhood or unknown vaccine date, so this is people that could have had vaccinia vaccine, so that older cohort, they start to be a very small group, the green here. And then we see in the people with early post-vaccine, the orange. Early on, when we were chasing to get the vaccine out there, really our PEP approach, we may have been catching people in attenuating disease, but not preventing or providing sterilizing immunity. Now that purple group, those people that have had vaccination more than 21 days prior, is starting to make up a bigger group. Now, that's not a failure of vaccine per se. That's actually something we see with effective vaccine campaigns. You're targeting the highest risk population, and over time, as you saturate that population, there will be some breakthrough. This is not a 100% protective vaccine, and it doesn't document the severity of disease. But anecdotally, I've seen most of my patients that have had vaccine and developed monkeypox tend to have much milder disease. I highlighted that there is supply chain issues. And so one of the approaches that's been taken is a vaccine sparing strategy or dose sparing strategy. And so on here, your typical vaccines you're used to are subcutaneous or intramuscular. The recommended dose was subcutaneous here, but by giving an intradermal vaccine, so you can see here going right at that interface between the epidermis and dermis, a much smaller amount of vaccine is required to generate immune response. So you can actually get 5 times the dose per vial by doing this. And this has been encouraged to expand the amount of vaccine we have given limited supply. This approach requires skilled nursing. It's much more difficult to do intradermal. I don't know if you've tried it. It's tough. I've tried tuberculin skin test would be something if you're familiar with that. It's also potentially going to cause scarring in individuals that are prone to developing that, such as keloid scars. And so darker skinned individuals or people with a history of keloids would be someone we avoid this in. So right now, for immunocompetent individuals more than 18 years of age and less keloid scar risk, they're recommending subcutaneous. And as of October 3rd, we are recommending second dose vaccine in the province for all individuals that remain at risk within those risk groups. So a whirlwind there, but to conclude and highlight kind of what all three of us have talked about is that monkeypox is spreading in countries without disease burden historically. And this is currently predominantly affecting the GB-MSM population. Transmission at this time does appear to have largely sexual activity relation to it, and so sexual transmission, and that the vast majority of patients require supportive care. Our major tool to prevent this, or a countermeasure, is vaccination. And these are safe vaccines that are effective and should be used in a 2-dose series, and dose sparing can involve that intradermal route. We're still developing understanding of how effective they are, but it does appear from early preliminary reports that they are effective. Some of the big fears are, do we get an animal reservoir? This is, unlike smallpox, animal and human infection, and that makes it much more difficult to eradicate because you can't get to necessarily those. My fear is what happens if the squirrels in Stanley Park start being the reservoir? That'll keep an infectious disease doctor up at night. It's really unclear if monkeypox will become endemic and that these non-traditional transmission networks will continue, but we have to be vigilant. And this has been an excellent example of how we have to be ready for these emerging diseases. So that's all I got, but I think all three of us are totally open to any challenging questions you have. I'll invite my co-speakers to come up if there's any questions for the group. I think we also have online participants, but Barry, you're the tech guy, right?
If I'm the tech guy, we're not.
And there are the microphones. I think you tap down once. Feel free to.
Maybe you could just.
Yeah. Or you can just yell it out and one of us will repeat it.
So lessons learned. Talked about the direct messaging about sexually transmitted disease, where this was thought not to be related to approach. Can you comment on that? I mean, just how long was the debate about that?
I mean, I think it is quite, I will say public health was very quick on the ball to pair up with our community partners. So within the first few days of June, they were already having meetings with a number of the stakeholders from the community about the messaging. And I think, there was very good uptake in terms of wording that gave people advice about how to minimize their risk. I mean, they didn't come right out and say this could be sexually transmitted, or this is a sexual transmitted infection, because I think we didn't really have strong enough data to say at that point that was the case. But the wording that they used, I think, gave people enough indication that it was clear that this could be a way, if it's not through sex or sexual fluids at the time of close physical contact. So I was actually quite impressed with how quickly they had a community advisory group, how quickly they were developing community-based messaging and wording. So I think they actually got on top of that, even if they didn't use the words. There's enough information to have people make an informed decision about what they were doing.
I think although there was some kind of sputtering at the global public health level, BC, I think, has shown a particularly accelerated approach and a nimble approach as well. So if you look, we've administered about 20,000 vaccines. And part of that is because of the network that pre-existed. And something I didn't show, but there's excellent patient information as well, really kind of culturally appropriate patient information, handouts that are given, word of mouth, utilizing modern apps as well for communicating, where people are communicating, put the message there. And so, having advisory groups has been so important. And certainly BC is now reaching out to other provinces. If you aren't using your vaccine, well, we have now with our second dose approach, the need for it. I think that, a lesson learned is that it's important to have those pre-existing infrastructures.
Yeah, they were very creative. I mean, they took a van down to Stanley Park to Wreck Beach. They actually got the vaccine out into places where people would not have been coming into the clinic to get it done. So I think we definitely have to give kudos to our public health colleagues in that regard. They were very quick on the ball once decisions were made to do something.
Are we sequencing the whole genome of the virus at CDC, and does that provide any information? Or is there no need to bother?
So the genome is 30,000 base pairs, so about 10 times larger than with SARS-CoV-2. So the intensity or the time required is longer. I think one of the key things that we've learned from genome sequencing globally for this outbreak is it's identified three clades, and the current outbreak belongs to the clade 2B, which previously was named West African clade. They've identified through genome sequencing that this outbreak, actually, with the source of the outbreak may have been much longer than what we previously thought. Through genome sequencing and host enzyme editing of the virus, it appears that there are transmission chains that have been undiscovered, and also in this outbreak identified 4 or 5 isolates that don't belong to this outbreak yet are circulating. So in the US, 2 cases have been identified that don't belong to it. So I think the genome sequencing data is beginning to tell us at least some evidence of evolution of this virus and how quickly it's expanded. In Canada, we've been slow compared to other countries to upload the genome sequences for comparison, but they have the data.
That's part of a trend of slowness in sharing genome sequences. So what you're saying is that there was monkeypox circulating that wasn't related to this?
As well, yes.
And it was
so
never
since this outbreak has been identified, they've also identified cases that actually were related to say more closely related to the 2017 Nigerian.
Interesting. Okay, thanks, Victor.
Just to add to that, there's a global surveillance failure here too. So since 2003, when there was a cluster in the United States, there's been intensified interest, but this was going on for 30 years before that in Central Africa. Yet the number of sequenced genomes that were available for public access was negligible. Now there's a bunch. And so this is another failure where we need to be thinking at the source. And so although we may be able to approach it here, we need to concurrently be addressing this. And we had tools to do this in Central Africa.
Not just for diagnostics, but for treatment as well. I mean, I think that's one of the limitations that we have to look at is, we've had an antiviral agent, which we're now going to evaluate in North American context, which is, they've been having ongoing monkeypox in African settings since forever. Why have we not done a clinical trial, a decade ago there? So it definitely tells us that we have, quite a lot of blinkers on in terms of how we look at things at a global level.
Speaking of blinkers, the most obvious source of infection is as we pointed out, but in the predominance was 97 or 99%. And it seems that that's the reason that monkeypox is seen in males. But is there some form? It must have been some female contact along the line.
Yeah.
So is there some protection? I guess is what I'm asking. I've never heard of this, but this is a really bizarre question. But why aren't we seeing this more in females?
I think at the moment it's just sexual networks. So, the initial case series were in some of the steam houses and, big sex parties in the European context. And it's just spread through the sexual networks from there. If we look at US data, I think about 2% of the cases are women through, the bisexual men that are having female partners. So they're not getting exposed to it. And in the US as well, they've even had pediatric cases, which is probably from fomites, in the environment. So I don't know that we can say that women are protected. I think it's just being a matter of where the initial infection occurred and it spread through, sexual networks very rapidly. I think it tells us how globalized our communities are. So, people travel, it's very quick. Once something occurs somewhere, we have to expect it's going to become a global thing very quickly.
Yeah. And with Nigerian data, they actually have higher predominance of females as well. And similar to other sexually transmitted infections, we can think about this as a initial community that's at risk, as well as a bridging community, and then the larger population. So I think it's just hasn't yet reached a high enough bridging community to be able to spread to other networks.
I think Gil had a question next.
Thank you. I was just gonna ask, on the slide you showed where the purple, for people that had vaccination that were getting infected, is that a normal ratio for other vaccination procedures? And I was just thinking if incubation period was 9 days, would expect to be a little bit less in an effective vaccine.
Good question. So can we compare this to other vaccine preventable illnesses? I don't have a great answer for you there.
Like
I think
measles, it would be a lot less than that, right? Purple bar,
Yeah.
very close to 0.
the incubation period here can be 7 to 21 days. It could be longer. And people that have been vaccinated, it may be even longer. They may have kind of an attenuated period of low level infection. But my understanding when I spoke to the BC CDC team about this is that this was not a surprise. That this is fairly common for them to see as we saturate the highest risk population. The further out we get from a vaccine like this, we will get some cases. What's not included here is what's the severity of the illness. And we are doing that reflexive testing and much more vigilant testing. And so we'll be picking up cases that may not be clinically apparent disease.
And also in speaking to Danuta Skronsky, who's one of the vaccine leads, she helped advise, identify the vaccine effectiveness, and the traditional sort of test negative case control studies that were done with respiratory viruses is a lot different in the setting of sexually transmitted infections because it isn't as if everyone is at the similar risk. So when you have a respiratory virus, that test negative design to estimate vaccine effectiveness can't necessarily be used here because of super spreading through sexual networks, as well as limited host populations that are susceptible.
I mean, I also think we also know this is only after 1 dose of the vaccine. So, I mean, the original data sets that we have were derived from the 2-dose vaccine. So maybe we're getting a bit more spillover in this first after just 1 dose. So I think it's a lot to learn.
Mm-hmm.
On behalf of ourselves and our distributed audience, thank you very much for a very entertaining and informative round.